Good morning, everybody. Sorry for the slight delay. Welcome to everyone online. Today, we have Dr. Retief Hospital presenting to us. He had attained his bachelor's degrees in medicine and surgery from the University of Pretoria in 2005. He then completed his internship at the Piet Retief Hospital in 2006. His community service year was spent in Emalahleni Witbank, where he spent as much time as he could in the surgical department. He worked as a medical officer in the surgical department for a year, awaiting a position as a medical officer in the Ophthalmology department. Dr. Dayaram underwent intensive and thorough Ophthalmic registrar training at the University of Wiwatersrand registrar circuit. Here he spent most of his time at St. John Eye Hospital, but also rotated through Charlotte Maxeke, Johannesburg Academic Hospital, Helen Hospital, and Lenasia South Community Health Centre. He received his fellowship from the College of Ophthalmology, South Africa in 2015. He then further completed a dissertation entitled Visual Acuity Outcomes Achieved Post-Cataract Surgery at St. John Eye Hospital in order to obtain a master's in medicine degree in ophthalmology. Today, Dr. Dayaram is a skilled ophthalmologist known for his dedication to patient outcomes with a commitment to excellence in clinical practice. His holistic approach to patient care ensures that he addresses the unique needs of each individual, making a meaningful impact in their lives. Thank you so much for presenting to us again.
Thanks, Dr. Gardino. Okay, so today I will be discussing ocular complications of systemic medication. I thought this would be an interesting topic because we have encountered some of these patients and we were surprised and caught off guard with these patients. So I thought, it's good to remind everyone that there are sometimes ophthalmology complications that occur from the medications that you prescribe on a daily basis. For today's talk, we'll be discussing a short discussion on ocular physiology and drug interaction. Side effects it's not really side effects, it's more complications that occur with regard to these drugs because the drugs are not always used how they should be used. Complications as a result of GLP-1 agonists. So GLP-1 agonists are the number one interesting drug these days, and everyone wants to know whether it's safe to go ahead and use them. And just for interest sake, is your GNT going to cause maculopathy in your eye? So let's get started. So with regard to how medication enters the system or can affect the eye, you can get medication through the systemic circulation or topical application. Usually topical application, it's us ophthalmologists dealing with it. A lot of the time, patients are given medication by GPs and others, and sometimes we see complications as a result of those medications. So I'm going to try and keep it as broad as possible. So hopefully there's a drug for everyone in this talk, even the rheumatologists and so on, obviously. Basically, any drug that's administered deals with one of these two ways of affecting the eye or needs to deal with these two properties. The first is ocular blood barriers. So some drugs can't cross the ocular blood barrier, and that needs to be taken into account when administering drugs or prescribing medication. And some drugs' chemical properties can cross the ocular barrier, and there they can cause ocular complications and adverse effects. So how do these drugs cause complications? So you can have direct toxicity due to drugs damaging cells in the eye, retinal cells, corneal cells, lens cells causing cataracts. And then you have accumulation of ocular tissues, accumulation of drugs in ocular tissues, which over a period of time cause chronic damage in the eye. You can have immune-mediated reactions, so drugs that can cause inflammation in the eye. So that's uveitis or retinitis in patients. And some drugs just affect the physiology of the eye and can cause complications in that way. The complications that can occur as a result of drugs, different drugs, most common, dry eyes, keratopathy, glaucoma, cataract formation, uveitis, and the more serious ones are your retinopathy and ophthalmology. I'm not going to talk too much about dry eyes. I've just given a list here. You can look at it in later on also, because dry eyes is actually a talk on its own. A lot of patients on antihistamines that tends to dry their eyes out and decongestants this time of the year. Your antihypertensive beta blockers can cause dry eyes. So dry eyes will cause your burning red eyes, diuretics, antidepressants, obviously isoretinoin. So all your people on Roaccutane. Parkinson's disease medication can cause dry eyes. Hormonal therapies, we know that. Chemotherapy has also been linked with dry eyes in patients. So this is a picture of a very dry eye. You can see with fluorescein staining, the epithelium of the cornea has basically been eroded. So this is called superficial punctate keratopathy up here. And that's obviously an abrasion down there. And this is actually just due to dry eyes. And it's very painful, very, very uncomfortable. And it's weird telling your patient, listen, you just have dry eyes, but they don't understand, like, why is my eye so sore? Management, tear substitutes, we all know that. There are some very good tear substitutes on the market these days, preservative-free, that last long. Punctal occlusion can be done in the rooms. We combine topical steroids with tear substitutes also for a period of time sometimes. Chloromethanol is very effective. Omega fatty acid supplements. These have, well, some patients say that they do get relief with taking omega fatty supplements. However, studies have shown no objective benefit for dry eyes. But some patients will swear by it. These can actually even get the omega supplements in your eye drop. So, for example, you have a product called Optiv Omega that has omega supplements in the eye. It's vegetarian, so the eye drop won't smell. So that's at least a plus there. Cyclosporin, serum eye drops, patient's own serum can be utilized. And also then we look at environmental factors, air conditioning, humidifiers, and so on. We also, surgery is always on the list here. We can reduce the size of the opening of the eye, and then that can also help with dry eyes, but we don't like to go there, but just for dry eyes. Let's get down to keratopathy. So vortex keratopathy is the most commonly seen ocular complication of drugs. And you get this beautiful whirl-like keratopathy on the front of the patient's cornea. It's ideally seen by tilting your ophthalmoscope and viewing the cornea from the side. And these are generally caused by your antimalarials, your chloroquine, hydroxychloroquine, and amiodarone. My father-in-law's got amiodarone-related vortex keratopathy. He doesn't report any change in his vision, but some patients will experience halos around lights, especially with your nighttime driving. Chlorpromazine, Largactil, can cause yellowish-brown deposits on epithelium and stroma, epithelium and stroma of the cornea, and capsular deposits on the lens. So obviously, when the patient's not dilated, this would affect the patient's visual acuity. I hope you guys can see this here. This is about the best image I could get on this. Argyrosis, silver deposits. Patients taking colloidal silver cause problems for us because we can't figure out what's happening with them. And a lot of people are using colloidal silver mouthwashes and drinking it and ingesting it when they shouldn't. You do see these grayish-brown deposits on the eyes, which is usually innocuous. However, neurologically and with regard to the kidney, then you can have other problems. And I thought I'd include gold used by the rheumatologists. You can get this purplish glittering granules throughout the cornea and lens deposits. This is also innocuous in patients, so it doesn't cause any problems. Glaucoma, right? We all know glaucoma is loss of peripheral vision associated with optic nerve damage. And on OCT scanning, I'll show you guys some OCTs a little later. OCT scanning, we see loss of retinal nerve fiber layers in these patients. Prior to the invention of OCT, we did visual field testing on these patients, and we saw peripheral field loss in patients with glaucoma. And if we can't take them off the drug that's causing the problem, we use topical glaucoma medication. Ophthalmologists love lasers. We can use lasers, and we can also perform surgery for glaucoma if the patient can't get off the drug. And here we can have patients with increased or normal intraocular pressures. So your culprits here are your topical and systemic corticosteroids, which many of us around the table use very frequently. Tricyclic antidepressants, topiramate. Hydrochlorothiazide was a surprise for me when I was researching the stock. Go-trimoxazole, Pervac, can also cause glaucoma. So it's not a bad idea to send these patients through for screening if they start to notice any visual disturbance. Usually the optometrists do pick up abnormalities with regard to pressure, but if you're not certain and patients start complaining, then it's not a bad idea to send them for screening, especially if they've been on corticosteroids for a long period of time. I'm going to go next slide. Okay. Let's move on to cataracts, ophthalmologist's favorite topic. So medications causing cataracts, most commonly corticosteroids, again, systemic and topical. These patients get a posterior subcapsular cataract. So here's a cornea. The light's coming in from the right of the screen. That's a cornea. This is the anterior capsule of the lens, and this is the posterior capsule of the lens. So here you can see a posterior subcapsular cataract. It kind of looks like frosted wind, like the glass of a frosted window. So it tends to scatter light for patients, and they struggle with nighttime driving. So initially, these patients start off as posterior subcapsular, and then it kind of moves to the anterior subcapsular region. Patients that are safe are patients with on prednisolone, less than 10 milligrams of prednisolone daily, or that have been treated for 4 years, and these guys will probably be immune to cataract formation. Early opacities may regress if therapy is discontinued. So we saw this in a pediatric rheumatological patient. She was about 7 or 8 years old, and she started developing posterior subcapsular cataracts because of being on corticosteroids. So we gave her a corticosteroid break, and 3 months later, the cataract just disappeared as if it wasn't there, which was very strange and good to see also for the patient. Busulfan, a very niche drug used to treat chronic myeloid leukemia, can cause occasional lens opacities. I couldn't get an image of that for you. Sorry about that. Gold can cause anterior capsule deposits in 50% of patients on treatment for more than 3 years. This is not gold deposit in the eye. I also struggle to get an image of that in the library. This is actually a Christmas tree cataract. I thought it looks quite pretty to show everyone a cataract like this. It's you see it more in patients with muscular dystrophy. Allopurinol, patients on Puricos for hyperuricemia and gout. It's more the elderly patient. And especially the cumulative dose exceeds 400 grams, so it's almost half a kilo cumulative dose. All patients on treatment for more than 3 years. These tend to develop cataracts a bit quicker than others. Your inflammation, iridocyclitis. Iridocyclitis is a more modern term for uveitis. It's more descriptive, and it's easier to pronounce than uveitis for everyone. So rifabutin, we all know rifabutin around the table here, used for the management and prophylaxis of Mycobacterium avium in AIDS patients with low CD4 counts. And these guys will get an anterior uveitis. So this is an anterior uveitis with a hypopion. So you have a collection of white blood cells sitting here. So it's a sterile hypopion. It's not endophthalmitis, but it can be mistaken for endophthalmitis in this case. This is a very painful eye for this patient. This is a milder version of anterior uveitis. So with withdrawal of the drug or reduction of dosage can help resolve the uveitis in this case. All right. So retinopathy, the more serious conditions. It's usually anti-malarials, which obviously are used to treat malaria. Rheumatologists use it for your rheumatoid arthritis, juvenile idiopathic arthritis, and SLE. Also, many of us are around the table, I know the nephrologists also use antimalarials. These cause a problem because they're excreted from the body very slowly. They're melanotropic drugs and become concentrated in melanin-containing structures of the eye, such as the retinal pigment epithelium and the choroid of the eye. Here your culprits are chloroquine, where you're safe. Your patients who are safe have a cumulative dosage of less than 100 grams in their lifetime, or duration of treatment less than a year. So this is also debatable because it depends on your patient's weight, the systemic other medical conditions, and glomerular filtration rate and so on. But generally, these are your safer patients that are more safe than the ones with a cumulative dose of more than 300 grams in a lifetime. Hydroxychloroquine, much more safer than chloroquine, and you can get retinotoxicity. Sorry about that. Retinotoxicity is negligible if the daily dose is less than 400 milligrams a day, and it increases if your daily dose exceeds 6.5 milligrams per kilogram for a period of more than 5 years. So I've concentrated quite a bit on this because it's very important, and these patients need to be followed up very, very closely. Let's look at what it looks like. So no single diagnostic test can reliably detect retinopathy. So this is part of the reason why we keep on buying equipment and more equipment and more equipment. And I have a Hyundai Accent that I need to drive because of the equipment. Fundus autofluorescence is a very good way of noticing. Here you can see fundus autofluorescence on the right here. Spectral domain optical coherence tomography is also useful. Fluorescein angiogram, we're trying to move away from fluorescein angiogram, but a lot of us do require it still. Electroretinogram and visual field testing is important. So we test the central 10 degrees. Once patients have maculopathy, it is not reversible, and there is no current treatment at the moment. So you have to recognize these patients at a very early stage, before any retinal pigment epithelium loss. All right. Here's an image of pre-maculopathy. Patient would have normal vision with an abnormal visual field test, but this is done with a red target because your central vision is, in your central vision, you have more cones than you have rods, and those are sensitive to a red target. On ophthalmoscopy, you will see no foveal reflex. And if you stop treatment here, patients, the maculopathy can actually be reversed. However, if your patient starts to lose vision and you go down to 6/9 or 6/12, which is 60 to 50%, you start seeing a bullseye macular lesion, a subtle bullseye macular lesion. Right? So this is a retinal image, and this is an OCT. And if you start seeing this type of damage, it may be too late, and this type may still progress to the severe stage despite discontinuation of the drug, which is very scary because now you have a patient that loses their central vision. Moderate maculopathy is patients with visual acuity of 40 to 25%, actually it's the other way around, anyway. And here we have, you can either have perifoveal, pericentral, and this is a mixed pattern in these patients. You can see that the photoreceptor layer here falls flat, and that's why they don't see in this area of the eye, in central pericentral area. Severe maculopathy, patients are basically blind, so they have vision of 16 to 10% and widespread retinopathy, retinal pigment epithelium atrophy. You see on their visual field tests, they do have tunnel vision with a little bit of central area spared, on visual field testing. And this is very disabling for patients. And, they're considered blind, not able to function and work with this type of damage. And this is the end stage of the disease. Here, patients have severely reduced vision. You can see the underlying choroidal vessels. So these are all underlying choroidal vessels. And arterial attenuation, see how narrow the arteries are here? And all these pigment clumps in the peripheral retina. So when do you screen these patients? Baseline screening is recommended within the first year of commencing chloroquine or hydroxychloroquine. We like to add perimetry or visual field testing and an OCT, especially if we have maculopathy present due to other conditions. Annual screening is recommended after 5 years, but it should be performed sooner, probably yearly after the baseline screening, if your daily dosage of chloroquine is more than 2.3 milligrams per kilogram, or hydroxychloroquine dosage of more than 5 milligrams per kilogram. Patients with reduced glomerular filtration rates. So here we had a patient who was on it for about 7 or 8 months, but she was quite elderly and she had reduced glomerular filtration rate and she had advanced maculopathy in her case. Patients using tamoxifen concomitantly with the chloroquine and presence of other maculopathy like age-related macular degeneration, something like that. These patients need to be seen sooner. We're moving on to your phenothiazines, thioridazine. I don't know if it's still used quite often by Dr. Taban and company, but according to the textbooks, it's also used to treat schizophrenia in the past. Doses which exceed 800 milligrams a day for just a few weeks can cause visual impairment. And you get a salt and pepper pigmentary disturbance. So a salt and pepper pigmentary disturbance kind of looks like your salt and pepper crisps from Woolies. So it's a dark and light type of a color pigmentary disturbance. Patients can get loss of retinal pigment epithelium and choroid capillaris. Chlorpromazine can also cause a non-specific pigmentary granularity. Moving on to your crystalline maculopathies, tamoxifen. So tamoxifen is very readily used. It's an anti-estrogen drug for breast carcinoma. Your usual normal dosage is 20 to 40 milligrams a day. And patients who are on higher doses can get retinotoxicity. Here, patients develop fine bilateral yellow pigment crystalline deposits around their maculas, and punted gray lesions in the outer retina and outer retinal pigment epithelium. These patients also develop visual impairment. We can't really improve the vision once there's visual impairment. Canthaxanthin, used for sun tanning. Some patients love this stuff. The eyes should be checked. It's, however, an innocuous condition which gives you glistening yellow deposits in a donut shape. This is an image of canthaxanthin toxicity that I found online, and I thought it was more interesting to show you than a donut shape here because that's almost a donut shape also. Right. More crystalline maculopathies, nitrofurantoin. Lots of our patients are on it. It's used to treat urinary tract infections. Patients can develop slight visual impairment. And on examination, they have deep and superficial intraretinal glistening deposits on the back of the eye, the posterior pole. Methoxyfluorine. Casualty users benthrof relatively frequently as opposed to anesthetists. It's metabolized to oxalic acid, and that combines with calcium and forms an insoluble salt deposit on the retinal pigment epithelium. And these patients get mild visual impairment. Okay. Let's move on to our more miscellaneous agents. Interferon alpha, used to treat Kaposi sarcoma, hemangioma in infancy, cutaneous melanoma, renal cell carcinoma, lymphoma, and chronic hepatitis C. So here, these are cotton wool spots. Remember those from undergrad. Most people will remember cotton wool spots. And you get intraretinal hemorrhages in these patients. And this usually resolves on discontinuation of interferon alpha. Also, they can get macular edema. So this is an OCT scan of the macula, and you see the cystoid macular edema here. Patients can develop ocular nerve palsy, so they will complain of binocular diplopia, optic nerve edema, and the serious one is retinal vein occlusion. Desferoxamine, it's an ion chelator, sorry for that. And it's used to prevent hemosiderosis. And patients develop a pigmentary degeneration of the retina. Can be macular or equatorial. So equatorials on the equator of the eye peripherally. Patients will have decreased vision, color changes, impaired night vision, and constriction of the visual fields. Right? Nicotinic acid, niacin, vitamin D3. Patients develop what appears to look like a cystoid maculopathy, suggestive of cystoid macular edema. However, on fluorescein angiogram testing, we don't see leakage. So that means it's not really macular edema. It's just a cystoid appearing maculopathy with mild decrease in vision. Because it's affecting the macula, they may complain of metamorphopsia or distortion of vision. Commonly occurs with dosages of more than 1.5 grams a day, and you just need to stop the drug, and that should resolve with stopping the drug. Another problem we had in our hospital, we do see some patients with ethambutol optic neuropathy. These are sometimes patients who are on ethambutol for longer than they should be. They present with painless blurring of vision, and sometimes it's central blurring of vision or peripheral blurring of vision with impaired color vision. So you can see these optic nerves don't look healthy at all. They're quite pale and a bit swollen there. Patients with ethambutol toxicity will have eventually develop severe reduction in vision. Our patient could hardly navigate on his own with ethambutol toxicity that we picked up. Patients may have a completely normal optic nerve. So you can be thrown if the patient doesn't give you a history of taking ethambutol. Sometimes the patients can have little-shaped hemorrhages. And a normal pupil also. Red-green dysphotopsia, so struggling to differentiate between those two colors, is the most common objective abnormality of color vision. But early defects can show blue-yellow defect. Early optic neuropathy can develop blue-yellow defects. Right? And in visual field testing, patients can have a central area of scotoma, peripheral, or bitemporal areas of scotoma. So let me show you everything. It's a bit of a busy slide, but we're going to just keep it basic. This on the left is an OCT scan of the right nerve and the left nerve. You can see there is thinning of the retinal nerve fiber layer here temporally in the right eye and temporally in the left eye. And on visual field testing on the right of your screen, you can see temporal visual field defects in this patient. Sometimes we can't do the visual field testing because the patient's visual acuity is too poor to see the target that's in the visual field machine. Right? Prognosis is usually good following cessation of treatment, but recovery can be prolonged. Our patient took about 4 months to regain vision. And there was a lot of problem with regard to loss of income, and he had to get someone to drive him around and so on. A very small minority sustained permanent visual impairment and optic atrophy. It's important to perform a baseline visual acuity and Ishihara testing. So this Ishihara testing chart is available on apps these days. It's on the My Callback app, or you can just show them something red if you have something red around. Ophthalmologists always have something red lying around. One of the bottle caps is what we usually use. But also tell the patient, listen, look out for any abnormalities in your eyes. And it's rather safer to be vigilant and then miss it. Repeat testing can be performed frequently with these patients, possibly monthly, with regard to noting whether they have reduction in vision and loss of color perception. And it's important to stop ethambutol immediately if toxicity develops. And if they're on isoniazid along with it, that's also needs to be discontinued, the isoniazid. Right? I don't know if vigabatrin is still used frequently these days. It can cause binasal visual field defects, but Dr. Taban says it's not really used that frequently anymore. So we'll skip that. Let's go to isoniazid. Isoniazid can really cause toxic optic neuropathy, but when combined with ethambutol, the risk increases. Methotrexate. Methotrexate is a very rare cause of acute or gradual visual loss due to optic neuropathy. Patients will have reduced vision, dyschromatopsia, so they will struggle with color perception and may have visual field loss. This could be linked to folic acid metabolism. So patients on methotrexate usually have the levels checked and get vitamin B12 or folate supplementation, which will help. Let's go to the interesting one everyone's worried about, the GLP-1 agonists.
Right? Yes.
Pardon? Oh, yeah. So everyone is concerned about it. You have heard people worried about the eye with regard to this, besides the other issues of pancreatitis and so on. Basically, we all know it's a class of medication, often administered via injection or tablet, and it mimics glucagon like peptide 1. I'm an ophthalmologist, so I'm not going to go into that as much as you guys know it. You guys know it better than me. It's used to treat type 2 diabetes primarily, for good blood glucose control and help with weight management. It gives patients a sense of satiety. Patients may complain of blurry vision initially on commencement of GLP-1 agonists, and this usually resolves within a few months. Can be very irritating to patients. I mean, if you have a bit of blurry vision, it may be dangerous for you to drive on the highway and work. So it's important to inform your patients about this prior to starting them on it, because they don't like to be ambushed and suddenly can't see and they complain that they're blind. More serious complications from GLP-1 agonists that have been reported is your non-arteritic anterior ischemic optic neuropathy. So suddenly patient cannot see from one eye and it's permanent visual loss. Patients can develop macular edema causing blurry vision or metamorphopsia, distortion of vision. And it has been shown to worsen existing conditions in the eye. So if your patient has diabetic retinopathy or age-related macular degeneration, strangely enough, GLP-1 agonists can cause progression of those two conditions. So I included some interesting pictures here. You can see the patient at the top here has a normal right eye at onset with a normal visual field. That's the blind spot, the natural blind spot where the optic nerve is. Here you can see optic neuritis in this patient with loss of field. And upon resolution, you see a pale optic nerve. So you know that this patient has optic neuropathy. Here's an OCT scan. This image here is in color because the machine set to color. So you can see clearly macular edema here, cystoid macular edema present in this case. Right? Other commonly used drugs, I won't go into it, others will be here for so much longer. Combined oral contraceptives can cause retinal vascular occlusions and optic neuropathy. Flomax, this is more for ophthalmologists. It causes a floppy iris syndrome intraoperatively when performing cataract surgery. So we don't like Flomax, so we want to know which patients of ours are on Flomax before performing surgery. Sildenafil, tadalafil. They can cause non-arteritic ischemic optic neuropathy, color vision disturbances, blurred vision. When I did my undergraduate degree in Tukkies, Prof. Durkar Sommer's pharmacology textbook starts off with explaining how sildenafil may give you a blue tinge in your vision. I remember that very clearly. See everyone around me nodding. His famous first lecture, and everyone sits upright and listens to it, and then just before it knocks you off your feet, pharmacology was really tough. Chemitoxin can cause scintillating scotomas, blurred vision. So scintillating scotomas are like sparkly lights that patients may see in their eyes. Gabapentin can cause nystagmus, diplopia, and visual field defects. Your bisphosphonates basically inflammation of the eye, conjunctivitis, episcleritis, keratitis, and uveitis. Actos can cause macular edema. And in diabetics with retinopathy, it's advised to consider an alternative to Actos because it can worsen the retinopathy and the macular edema. Cocaine can cause retinal vascular occlusions, keratopathy, glaucoma, maculopathy, and infections and endophthalmitis. And let's get on to your GNT. Can your GNT cause quinine toxicity in the eye? It was just a bit of a rabbit hole I went down when looking at the chloroquine maculopathy. So quinine toxicity can primarily affect the retina, the inner layers of the retina ganglion cells, and it can potentially lead to permanent damage. The symptoms develop after hours after ingesting toxic levels, and they can include symptoms hours after toxic cells. They can include central visual field loss more than peripheral field loss. And sorry about that, I didn't include that here. And paracentral loss of visual field. This occurs at a dosage of around 2 to 4 grams of quinine taken once off, and they also cause severe poisoning symptoms. So just to put it into context, your tonic water has 67 milligrams of quinine per liter of tonic water. So you'll have to drink a hell of a lot of tonic water or bitters to actually get 2 to 4 grams. So the answer is no, you can enjoy your GNT tonight, right? In conclusion, it's important to just be aware that whatever you're prescribing can cause ocular complications. Keep it at the back of your mind. Some conditions like your ethambutol and methotrexate patients may need a bit of early monitoring for the vision. You're welcome to send them through. We can do that for you quite quickly. And also be wary of prescribing medication above safe levels and ensure that you bring them down to normal levels as quickly as you can. So thank you so much for having me. Any questions?
Thank you so much. I think when you took us back to school, and I always say that ophthalmology, when you look at ophthalmology, they don't look like part of medicine. They look like these people on the corner there because we always think that because we can see that does not mean, So I just wanted quick questions about, obviously you have made a lot of sounds about TB treatment and eye complications. One, does that mean that all patients before we put on TB treatment should actually be screened for underlying eye issues? And after 2 months of treatment, do they need to come and see an ophthalmologist? That's first. The second thing, obviously, is about perhaps looking at the other medical complications, obviously, of different kind of conditions that also affect the eye. How would you actually, if you haven't done pre-treatment kind of screening, how can you link it to that drugs? Because patients say I could see very well, but now they don't see very well. And because sometimes it's just like people say what they want to say.
It could be the condition that's causing an eye problem, or it could be the drug. So it's very difficult to figure out on your side what's causing it. Practically, it would be impossible to screen every TB patient for ocular pathology. I think it's more to inform the patient to just watch out or ask them, by the way, how are your eyes? Are you okay? Can you see well? Some patients won't be able to pick up early signs, so that is difficult. I think it's more the ones on ethambutol for a long period of time. So when you're prescribing ethambutol, maybe make a note in the file, check vision at next visit if the patient's coming back after 4 months or 5 months of ethambutol. It's with regard to figure out whether the conditions cause it or the drugs cause it, very difficult. I think we'll have to come and help you out with it on that in that instance. Sometimes patients just have normal physiological aging and they start struggling to see nearby and start developing presbyopia. They come in saying they're completely blind. And then when you put on reading glasses for them, they see much better. But it's tough suddenly being 43 and you need reading glasses. So a lot of them go into denial.
So those who just
So, yeah.
don't want him, they might need more bigger glasses.
They may,
So,
that's when you start
so
reading.
Yeah, so the interesting fact about our patient was he was on a very high dose of ethambutol, and he had underlying diabetes as well.
He had retinopathy.
Yes, so it was and then we found out that it must be probably due to the side effects of the ethambutol. But the things are, we see a lot of patients on amiodarone. So amiodarone you mentioned.
It's not a big problem.
Not a big problem. Okay, and then obviously the chloroquine and patients with they're on methotrexate and chloroquine.
So chloroquine is very, very important
Mm.
because with chloroquine maculopathy, if it progresses, your patient loses the central vision. So imagine having someone that's 40 or something like that, that's been on chloroquine for 5 years, who starts losing central vision. It's a huge problem. Patients can't work anymore. It's very disabling, and they can't drive anymore. So those patients should be screened actually quite often. Unfortunately, it's one of the things that has to happen. Chloroquine is a big problem for us. I believe I see some patients on hydroxychloroquine also these days. I don't know how patients get hold of hydroxy. Is it available in the market?
Which one is called weekly plasmapine?
Plasmapine.
Yeah, which one is hydroxy?
Well, plasmapine is equivalent to chloroquine. Yeah. But I think it's the rheumatology patients that Dr. Conray sometimes.
Just one thing about you spoke about pen frog. Now, pen frog in popular culture, there's a lot of conspiracies against pen frog as well. People say that it shouldn't be used. It's nephrotoxic, and the drug companies are hiding the information. But the bottom line is that pen frog in the inhaler, the green whistle that we call it, is a very low dose. It's only this little 3 moles, very low concentration. So it's just basically for pain medication.
Yes.
And I recommend you shouldn't use it more than once in 3 months. And if you use it that dose, there's absolutely no proof that it's got any permanent side effects. And it essentially is supposed to be, you can't use it. You can't use more than one inhaler on a day. So if you stick to that dose of pen frog, you should be completely safe.
Yeah, as far as I know, you should be completely safe.
Yeah.
This is in patients who've had multiple.
It used to be full use of general anesthesia and all in there.
Yeah, you don't get it. They don't use it at all anymore. They don't even. Some of them don't even know what benthrop is. The anaesthetists.
Yes.
Yeah.
And then another thing about the the quinine, the gin and tonic. Everybody always says people use it to prevent malaria because in the old days the quinine was quite high. But now, obviously, due to safety reasons, they've reduced. So it's just enough to still have that
I think for gin
tonic
tonic,
water taste.
I think for gin tonic, maybe we should just, you could have gone after test, you know. You have some cows.
Anyway, to go to the
With a cow dunk, elephant dunk, yeah.
No, I think I don't know how many liters you'll have to drink of the stuff. I didn't work it out.
It's hot day.
I was supposed to work
And we're working hard to get there, but
67 milligrams, so about 10. No, a lot. Yeah.
But look, as I say, medicine is really very interesting. That's really, thank you for this presentation. I think it's probably amazing that at least we could, recall back, and perhaps once we prescribe medication, we can have that background index of hearing your voice, criticizing the physicians for this jotting without preparing the patients. But now that you allow us to
Now, you were also talking about the Viagra and the blue discoloration. But the other one is digoxin and yellow, but that's not a side effect, or it's a side effect of the digoxin. It's not a toxic effect.
No.
It doesn't cause eye damage or anything like that. That's usually reversible.
Well, you say Viagra is it what for my hypertension or for the recreational purpose?
Well, it doesn't matter to me. I need to still screen these patients.
It matters.
It depends on how it's been, how much of it's been prescribed. So there was a stage when we have a condition called chronic cystoid Choroidal, retinal, choroidal, central retinal choroidal, CSCR. I can't remember the full term now. We don't have these patients are your type A personalities that develop macular edema or macular elevation, and we don't have treatment for it. And there was a stage where they recommended Viagra twice a day. It didn't work as well as amiodarone now works.
But then we also give out the background really for patients with
Yes.
end-stage diabetic,
Yeah.
and then how do you know between the two? Because I've been an opportunity diabetic, you obviously need that little help in the bathroom.
Look, on our side, if there is macular edema, we manage it with anti-VEGF medication, and usually it results with that, or intravitreal corticosteroid administration.
So in your opinion, we should screen all diabetic before we prescribe them Viagra, Cialis, all those, or not necessary?
All diabetics should be
get
screened in the new.
Yeah, but before we prescribe that, they should be screened, obviously.
Well, yeah, there will be screening. Yeah. The condition I was thinking of is central retinal choroidal retinopathy.
And just remind us again,
Sinus choroidal.
since we're on the screening for diabetics type 1 and type 2. So type 2, we always screen at the start. Type 1, we can wait.
I remember it being 5 years.
5 years.
Yeah, it's 5 years.
Well, because the type 1 for the student, they normally got what we call honeymoon phase. Like when you get married, you have no problem, no debts, nothing. So you have to reaccumulate the debts. While type 2 is all couple that's been married for a long time, they already have a lot of baggage. So you must start with counseling earlier. So that's how we actually look into diabetics. So that's the reason, because type 1, they will have immediately like that, no complication at all. Okay. So I think they used to ask the same question exams about the honeymoon phase in type 1 diabetic. And that's why normally they need little insulin and the sugar is quite well controlled as compared to patients that type 2 goes into quite insulin dependent. Yeah. So I think that's probably the logic. Okay. Any questions? Leanne?
No. Thank you so much. And just a reminder that if you want to rewatch, that the recording will be available on YouTube on the channel is called Sanocare Breath of Hope. Yeah.
And the channel is actually getting busier. We almost got close to 4,500 viewership. That's been amazing. And yeah, the year is coming to an end, guys. We have only 3 laps. I think we closing the official last presentation on 27th of November, and then we close for the year, then probably for next year. But thank you guys for joining us. Just a reminder again, we have presentation every Wednesday, and that's, I think there are quite a lot of good presentation for most of our colleagues today, the young practitioners, emergency medicine practitioners. We have yesterday good presentation about purpura in EC and all those. It's really big presentations that I'm going to share with Danny. And please log into our website and watch that, because that's what I present to EC, and then they tend to image diagnosis as acute abdomen. And then so at least you can, it's really quite state-of-art presentation, energetic yesterday. So please go back to our podcast and you can be able to view them. Thank you. In that case, any question online? Yes.
Okay. Yeah.
CM? Okay. EM, who is there? Who is having my initials? Who's the EM? EM down there. LCB, any questions? Okay, in this case, we're saying that have a lovely day. Bye-bye.
Bye.